Good morning. My name is Faisal Bakaeen. I'm a cardiac surgeon at the Cleveland Clinic. We are here at the 56th Annual Meeting of the Society of Thoracic Surgeons in New Orleans, Louisiana. We're having a panel discussion on CABG. We're going to address the controversy surrounding the EXCEL trial, then talk about the other recent trials comparing CABG versus PCI, and then finally conclude by thoughts on improving CABG with specific emphasis on the use of multi-arterial grafting. I have a great expert panel today that I look forward to tapping into their knowledge so that we can all have a great learning experience this morning. So I would start by asking the panel members to introduce themselves, maybe starting with Joe.
Hi, Joe Savick from University Hospitals in Cleveland, Ohio.
Mike Farku from the University of Toronto.
Joe Chikwi from the Smith Heart Institute, Cedars-Sinai, Los Angeles.
In the Mario Gaudino, Cornell, New York.
Okay, let's get to the chase. There has been a fair amount of drama surrounding the EXCEL trial. There has been concerns about whether the study design was biased in favor of PCI over CABG, and also perhaps that the all-cause mortality was not given sufficient attention in the recent publication of the 5-year results in the New England Journal of Medicine. Joe, as a PI or co-PI of the EXCEL trial and as a lead author, how can you respond to this and how can you help us calm the storm?
Sure, thanks Faisal, and thanks for the opportunity to talk about it. I suppose a lot of the question around the study has to do with the study design, particularly including the periprocedural myocardial infarctions in the endpoint, as well as the definition. You know, I think to think about this, I think there's a few questions we can answer. The first one is, should periprocedural MIs be included in an endpoint definition? Well, at the time, that was the guidelines, that when you're doing a revascularization study, you should include periprocedural MI. Also, there's always the question of power. You know, we'd love to do a study that just looked at death or you know, other endpoints that are single, but we just don't have enough events to power the study. And so prior to EXCEL, most studies also include reintervention. But we really wanted to look at what we thought were the 3 most important endpoints, which was mortality, stroke, and myocardial infarction in our primary endpoint. So I believe there's plenty of justification, both from a feasibility as well as a guideline suggestion to include periprocedural MI. The second question is, what should be that definition? And as you know, today we don't have a standard definition for periprocedural MI. There's still a lot of controversy as to what that should be. The universal definition has undergone 4 different definitions during the 10 years during which the EXCEL study was done. But either way, we had some criteria for what we wanted that definition to be. Most importantly, we wanted it to be prognostically significant. That meant that it had an effect. And as you know, we've published studies from the EXCEL study showing that our periprocedural MI was very prognostically significant for both CABG and PCI with equal effect in terms of mortality. The second thing we wanted to remove was ascertainment bias. You know, as you know, if a patient has chest pain after coronary surgery, treated very differently, probably with morphine, versus if they have chest pain after a PCI where they get an EKG and trip back to the cath lab. Also, getting post-op EKGs is different because of bandages, so we wanted to remove that bias. And then the third thing is we knew at the time that enzymatic levels were both prognostically important for both PCI and CABG, and so what was that level? There was a lot of data at the time, you know, demonstrating that it wasn't until you got to about 10 times normal that they became prognostically significant, and importantly, that the effect was equal on that. So I think that we sought out to do what we wanted to do, was to use a periprocedural MI definition that accomplished those 3 things. And all those 3 things were agreed upon by the surgical leadership and the interventional leadership in the study, you know, 10 years ago. In terms of the death, you know, again, it wasn't the primary endpoint, but death is the most important thing. I think we would all agree upon that. You know, you're given 2,700 words in the New England Journal. You're given only so many tables, only so many figures. What I'll say is that if you look in the abstract of the New England Journal of Medicine article, the second sentence in the results goes to death. It is mentioned multiple times in the results section of the paper. In both tables, we look at death at 30 days, we look at it at 1 year, we look at it at 5 years. There is a graph that depicts just all-cause mortality in the paper, and the majority of discussion, I would say over 50%, addresses death. And I think, very important findings, I think, of Excel, which unfortunately I think have been lost in some of this controversy, is that when we look at PCI and CABG, there are always more kind of peri-procedural issues around CABG. And so at least early on, PCI does better. But when you get out beyond a year is when surgery shines. The durability shows up. There's fewer reinterventions. There's fewer post-procedural MIs. And in Excel, we had more deaths in the PCI area. So I think that what Excel did for us, and what I'd love us to focus on as opposed to a controversy, is help us decide who to treat with which procedure. If we have an older patient with a lot of comorbidity, maybe stenting is better. But that young patient who are looking for a very good long-term durable result, Excel really demonstrated that surgery or CABG was the best thing to do.
Great points, Joe. Mike, you're a leader in the Freedom trial and experienced trialist. Do you agree with Joe? And if you were involved with the Excel trial, would you have done anything differently in terms of design and analysis?
Well, I first want to say that I agree completely with Joe. I think his summary is outstanding, and it's not a lot to add to that. But as a non-interventionalist, non-surgeon, a clinical cardiologist, the Excel trial is a very important contribution that really assembled a fantastic team, interdisciplinary team that I think is the standard for the future. And the trial was done in a way that was exemplary. So I think that that's important as we go forward. Now, there are concepts and there are issues about interpretation. I think first and foremost, the issue of peri-procedural MI, it does predict future mortality, so that in the early 3-year outcomes, I think having peri-procedural MI in the mix is important. We can talk about this as a conceptual issue, but as long-term follow-up comes, it really is about, you start to evaluate mortality. So although mortality was one of the subgroup and pre-specified secondary endpoints, it is an important one that we always think about. And I think that it is very, very important to lay to rest, certainly in the clinical cardiology community, we believe that the definition that was used was not changed. I think that's been reiterated many times by the investigators, and I want to say that up front as a neutral party. And I think the idea here is that when you look at mortality in the totality of left main trials, there really isn't a mortality advantage signal. So this is an exploratory hypothesis generating finding that I think is very, very important. Now, what would I have done differently? Well, first of all, I would have planned for mortality as an important almost a co-primary endpoint of the long-term follow-up, because everyone's going to look at mortality. And in fact, if peri-procedural MI is predictive of mortality, you're going to capture it as we follow patients long-term. The second thing that on a design issue, and I'm not criticizing anything, but I like definitions that are common to both arms. So in Freedom, we used the development of new Q waves at 1 month as the endpoint. It was equal and it was fair in both arms. When you start to have differential enzymatic levels, it raises methodologic concerns. And finally, I think we need more than ever to follow patients long-term in these revascularization trials. I think that to say that we're going to follow 3 and 5 years, we need out 10 years. We need to get the support from the sponsors to do that and from the federal agencies.
Thank you, Mike. That's a great perspective. And perhaps at this point I would ask Joanna, why do surgeons like Nobile better than Excel?
Well, I think that you could choose to compare those two trials and delve down into the nuances of design, p-values, endpoints. But I think what surgeons can take away is that there was a strong signal of superiority with mortality in Excel, and that's not different to the superiority signal that was in Nobile. For patients that are most of the 3-vessel left main stem disease patients that we see, the coronary artery bypass is going to offer them superior long-term survival and outcomes. And for those frail patients that we see in our practice that are clearly more suitable for PCI, PCI is a great option. But I think what we can as a specialty learn from both of these two trials is exactly what we've seen in other areas. So look at what's happened with surgery versus TAVR, and look at what's about to happen with MitraClip versus mitral valve repair in degenerative primary MR. We as a specialty have to be far more intentional about how we design these trials and execute them, how we report them, how we translate them into clinical guidelines, approvals, and practice, because these trials change practice. Joe's highlighted really importantly how the benefits of surgery are late. We see them after 1 year, after 2 years, after 5 years. And if these trials aren't powered and reported with that very, very front and foremost in mind, we are making life-changing decisions for our patients based on incredibly limited data. And the reason I feel particularly strongly about this is because the mitral arena is just about to get, I think, majorly impacted by the design of 2 trials that are just about to start enrolling. And we as surgeons need to collaborate far more closely with our cardiology colleagues and deliver robust, investigator-initiated, well-designed trials that truly inform practice.
Cannot overemphasize that point, Joanna. It's really how you design those trials, how you select your patients in those trials, what you choose at endpoints, how you analyze them, and the length of follow-up. So these are all important lessons for future studies that are going to impact our practice. And talking about other studies and trials, Mayo, you seem to know about everything that's happening in the coronary arena. Can you bring us up to date on the most recent CABG versus PCI trials, particularly the ones with longer follow-up?
Well, sure. I think the last 2 years have been very important in terms of getting new data about CABG versus PCI, especially long-term data. I think we had 3 very important publications. We had Stuart Head pooled analysis of 11 randomized trial, 11,000 patient published on Lancet. And that show a survival benefit in the CABG arm that was independent from the syntax score. And I think that was a very first important finding for us as a community. Individual trials were underpowered, like Joe mentioned, to look at mortality in the short terms. The use of a meta-analytic approach gave the investigator the opportunity to specifically look at mortality, and they found a survival benefit at 5 years. That's the very first important finding. The second important finding is that that benefit was independent from the syntax score. And the same finding was later confirmed in the syntax extended follow-up trial, where at the maximum extended follow-up of 12 years, there was a survival benefit for CABG. That survival benefit was not evident at 10 years. That was the pre-specified timeline for the analysis, but I struggled to understand the concept of having a pre-specified timeline and not using the full power of the follow-up when they were looking for an outcome that was not the initial outcome that was used to power the sample size calculation. And again, a survival benefit for CABG independent of the syntax score. And then Dr. Farku published the result of the extended follow-up of the FREEDOM trial. FREEDOM trial was specifically looking at diabetics, the mean follow-up of around 8 years. Again, surgery was better in terms of survival, and that was independent from the syntax score. So if I have to summarize, I think we start seeing that at long-term follow-up, there is a benefit for surgery, and that benefit is independent from the syntax score. We have used for decades the syntax score to inform our guideline and even in our decision making, and probably this is the time to start rethinking the role of the syntax score.
Thank you, Mario. Nice summary. So, Mike, how does the ischemia trial play into this? Should we expect, I should say, a drought in the referrals for intervention, both for PCI and CABG? What's your take on the ischemia trial?
So the ischemia trial, a very important contribution presented in abstract form at the American Heart and publication pending. So I'll just talk briefly about the design. It's really evaluating patients with moderate to severe ischemia on functional testing that are then subjected to either a conservative approach or to an invasive approach, with the caveat that patients have a coronary angio, CT angio, to rule out left main disease or the absence of disease. I think that's a caveat. And the trial, in a sense, the primary outcome of cardiovascular death, MI, and stroke was neutral. But there are interesting caveats here because there are important subgroups that are lost within the interpretation of ischemia. And I want to focus primarily on the diabetes patient with multi-vessel disease. I don't think it's going to change our practice. In fact, in Canada, the Peter Munk Center, where we practice, University of Toronto, it's not going to really change our practice because we have been much more likely to send patients to surgery than PCI, than other American centers particularly. And the idea here is that I think for patients where ischemia will have a big impact is in the asymptomatic patient. It appears that there really is no benefit in those patients, but when you look at quality of life for the symptomatic patients, a clear benefit of an invasive approach. So when we look at the diabetic patients, the multi-vessel patients, or maybe the non-diabetic, very advanced patients with aggressive disease, I don't think it'll change practice, but rather it's more of a correction on the symptoms versus asymptomatic issue.
Thank you, Mike. Perhaps we'll shift gears a little bit, and I want to start with Joe. You know, CABG has been around for over 50 years, and the outcomes have been improving steadily with time, despite the complexity of patients and the high-risk cases. But the actual construct of the CABG is LETA to LAD and saphenous vein grafts to other targets has been pretty steady over the years. And we know that the Achilles heel of CABG is diseased vein grafts. So what can we do as surgeons to up the game in CABG, enhance its durability for the benefit of our patients?
You know, that's a great question, Faisal. And, as you know, the most important predictor of how well our patients do after coronary surgery is whether or not their grafts stay open. If their grafts stay open, our patients do well. If their grafts close, our patients have problems. So we as surgeons, need to continue to use the best conduits possible. I know everyone here, we are all in favor of arterial grafts. And we know that one arterial graft is better than none, but two is definitely better than one. There's obviously a question as to when you get beyond that, whether it matters. I personally believe it does matter in terms of quality of life and relief of symptoms. So what can we do? I think we need to continue to approach this problem on two fronts. The first thing is kind of education and how to do it. And I think there's important education in, how do you harvest the arterial conduits, particularly when it comes to internal mammary arteries, so you don't have sternal wound infections. How do we do endoscopic radial harvesting? So I think as a group, we need to continue to drive the education of how to do such that that is no longer a barrier. The second thing, we need to do is to continue to explain why it's beneficial. I think probably everyone here has been involved in studies, demonstrating what we talked about, that multiple arterial grafts are better. And it's actually very hard to find a subgroup of patients that don't benefit. Only if they have, in my experience in a study we did, they have very poor ventricular function and have many comorbidities, which is, as you know, is a minority of our patients. So I think it's driving education on how to do it and why to do it.
Thank you, Joe. Well, you might agree or disagree with Joe because you looked, Joanna, at the statewide registry and you demonstrated benefit for multi-arterial grafting, but you did identify a subset of patients who might not reap the benefits. Can you please share your findings with us?
Yes, so the obvious limitations of looking at a registry rather than performing a trial of the quality of David Taggart's randomized trial is that you can't adjust for confounding variables. So there's an element of bias when you're comparing two populations. So the strength of that study is it tells us about practice variation. One of the fascinating things that we found was that the usage of multi-arterial strategies varied in surgeons from 0 to 100% of patients with a large scatter in between. And that tells us a lot. The second thing that we found that was interesting was that even if you think there's a bias towards the multi-arterial group, which should favor improved survival, which we certainly saw in younger patients, in the patients that were over the age of 70, we didn't see any significant difference in survival in a large registry, which tends to have a bias. So my personal practice and the lessons for my clinical practice from that is I would probably only use a multi-arterial strategy in a 70-year-old that looked like they had a fantastic future life expectancy. Going back to the practice variation, if we really want to move the needle on this, it's much as I think Roma is a fantastic trial and we can keep doing registry analysis until we run out of registries, the way to change practice is really to look at what metrics we're benchmarking our practice by. So, for example, the STS 3-star rating, if that included a multi-arterial strategy for patients under the age of 60, which I don't think is too controversial, or documentation as to why you didn't do that, maybe that would be enough to change the needle.
Mario, Joanna mentioned Roma, and there's not a single randomized controlled trial that demonstrates superiority of multi-arterial grafting over lead to LAD and veins in terms of survival. What can you say to change the heart and minds of the vast majority of the North American surgeons who use that construct, lead to LAD and veins, in about 90% of their practice? Do all roads lead to Roma?
Well, thank you, Faisal. Yeah, you're right. There is no single randomized trial that show actually not only a benefit in survival, but a benefit in any kind of clinical outcome with the use of multiple arterial grafting. And we were all expecting to have the final answer by the ART trial, but we all know where the design issue and the implementation issue with ART that led, I don't want to say to the neutral result, but at least to the fact that everyone has doubts about the final findings of the ART investigator. There's been a recent survey of UK surgeon, and the question has been asked why you don't use multiple arterial grafting more often. And the number one justification was the lack of randomized evidence. So I agree with Joe and Johanna, but I think we also need to provide solid randomized evidence that there is a benefit. Registry study, unfortunately, have an intrinsic bias that is basically our own judgment as a surgeon. We tend to use the best conduit for what we perceive as the best patient, and there is no matching technique that can account for that. So we need randomized evidence. Roma is underway. We are at 30% of the enrollment. The result will be probably ready around 2025. Still a long road ahead, but I think it's worth waiting.
I can't wait, Mario. Congratulations on your successes so far, and we all look forward in anticipation for maybe a confirmation of the superiority of multi-arterial grafting in the context of a randomized controlled trial. Until then, Joe, you're a leader in the field. What can cardiothoracic surgery leadership do to move the needle on CABG? Perhaps you could touch upon training, super specialization, quality metrics, finances, etc. Feel free to speak your mind.
Well, obviously all of those are important. I personally think the best avenues to go are with training and education. I think that's really the reason we do it, as long as we can do it for the right reason, the why. And so I think whether it's leadership or our societies, I think opportunities to continue to teach technique, whether it's with videos or hands-on labs. But I do think this active discussion at meetings just continues to bring it to the forefront. I think what we also can do, should we do quality metrics? Those in themselves tend to be controversial and sometimes the third rail. I don't disagree, but I think sometimes it's hard to get consensus in large societies that those are the ways to go. You can argue that you can make financial incentives. Should people be monetarily rewarded for doing multiple arterial grafting? Again, there's another opportunity, but probably again another third rail.
Well, on that note, I would like to conclude by thanking our panel members for a very enlightening discussion. And I hope that you, our viewers, would leave us energized and take CABG future into a brighter arena for the benefit of our precious patients. Thank you very much.